Excellent. Who's the cohort in the homeostasis class block right now? Okay. Alrighty. So these so my name is Kaveh Sadigh. I'm one of the clinical cardiologists at Stony Brook. Uh, and thank you to the faculty and the dean for inviting me this week to teach to you guys. I've done this series of lecture last year to the cohort before you. I recognize some of you guys. So this will hopefully be a review, but I've lined it up so it matches what you're doing in your homeostasis block. So today we're going to do a little bit of a lot of pharmacology in cardiovascular medicine. So it's important that we have a method in which we approach pharmacology. Let me know if I go off screen. Uh, in the way that I approach pharmacology and in the way that I approach really anything in medicine is systematically. So one of the advice that I would give you guys as you pursue a career in medicine is to have a method in the way that you approach problems. If you stay systematic, you will do just fine. All right. And the way that I approach pharmacology is based on a few tenets. You know what a tenet is? What's it? Yeah, a code of conduct. Yeah. Number one, what's that? A tenet? No. No, who plays in it? Oh, okay. No. I will cite movies though this week, so we're on the right page. Number one, do no harm, right? Do no harm. No matter how simple the problem in front of you or how complex the problem in front of you, you want to make sure that you do not harm your patient. Okay? Number two, every substance at a certain dose is toxic. Tylenol, toxic. Ibuprofen. Ibuprofen is probably one of the most toxic over-the-counter medications, and I'm sure the majority of us have used it in our life. Number three, with great power comes great responsibility. What movie is this from? Spider-Man, yeah. But it rings true. You'd be surprised how often I come back to this quote, to this tenet in medicine, that the knowledge that we have based on natural history of diseases, pathophysiology, and pharmacotherapy, you have to make sure that every single time you perform a test, prescribe a drug, the benefits outweigh the risk. So as I go through the next 90 minutes talking about pharmacology, you will begin to understand these three tenets and why I organize my thoughts in this way. Okay? I am somewhat arbitrarily going to divide drugs into two classes. One is going to be class one, and one is going to be class two. You can say class A, class B, class Y, class Z, I don't care. But in my mind, I will divide it up into class one and class two. And this class is going to be very effective. Where I'm for the most part, going to be talking about hypertensive pharmacotherapy. I'm going to sprinkle some heart failure in this as well. But these are going to be effective blood pressure lowering agents. And guess what their side effect profile is going to be? It's pretty good. Class 2, very powerful, significantly going to drop blood pressure. But the side effect profile here, not so great. So remember, everything we do in medicine, benefit, side effect. If the side effect outweighs the benefit, should you prescribe it? Probably not. And tests love this stuff. You can see here, I can tell you about medication, dose, side effect. It's such a big part of what we do in medicine, and so it has to be at the tip of your fingertips. Okay? So let's start with class 1. And again, I'm talking to you guys in this way, class 1, class 2, to organize our thoughts. If we were on the wards rounding together and you were like, I would like to prescribe a class 1 drug for hypertension, no one's going to know what you're talking about. There is no class 1. Does that make sense? If you look at JNC guidelines, actually, they'll just give you the class of drug. They're not going to tell you class 1, class 2. I'm just trying to help you formulate a system in which you can organize your thoughts. Okay? All right. What would you say is a effective class? Where is it? Yes, ACE inhibitors. Very, I would say in 2025, you have essential hypertension, first line therapy. ACE inhibitors or ARBs. ARBs are rapidly becoming now the drug of choice. But you are correct. ACE inhibitor, ARBs. ACE inhibitor, give me a drug. Uh, What is it? Ramipril, lisinopril, captopril. See a trend? Pril. ARBs, losartan, valsartan, olmesartan. See a trend? Tan, tan, tan. Side effects? What is it? Well, yeah, you're not wrong. These do drop blood pressure, but you can really make that case for any blood pressure lowering agent. What's a side effect very specific to this class of drug? Huh? For which one? Correct. ACE inhibitors, angioedema. What's the mechanism of action? What is it? Decreased? Increased. Why? Correct. Correct. Yes. It actually prevents the degradation of bradykinins. Bradykinin concentration goes up and it's an irritant, right? That is the mechanism of action of, I'm sorry, not angioedema, mechanism of action of cough due to elevated bradykinin concentrations. cough. The angioedema, the mechanism of action, is unknown. The funny thing about the angioedema with ACE inhibitors is that, unlike other allergic reactions, it's usually after the first 2 or 3 doses you get the reaction. With this, they're on it for years and then they develop it. And just based on these two, angioedema and cough, that tend to be the cough is very selective to ACE inhibitors. It's a very dry cough, non productive cough. What's the differential diagnosis for cough? A cold, bronchitis, asthma, GERD. I mean, you name it, postnasal drip. So you can't be like, oh, you have a cough, ACE inhibitor. No, there's a differential diagnosis for for a cough. With that being said, though, if it's an incessant cough and you've done your due diligence, you've ruled out some of the more common causes of cough, it can be caused by ACE inhibitors. So these two are typically pretty selective for ACE inhibitors. Although, if you have angioedema with ACE inhibitors, we tread cautiously with ARBs. Not to say the literature is strong, but the ACEs and ARBs are cousins in terms of makeup and pharmacology. So we tread cautiously. But the overall side effect that includes ACE inhibitors and ARBs, a big one is you tend to see a bump in your creatinine. Now, when you get to nephrology, your renal block, you'll talk about the efferent and afferent vessels of the glomerulus. But typically, you're allowed a greater than 30% increase in your creatinine for it to be acceptable. Anything greater than that, you DC the drug. Anything less than that, you continue the drug. Sometimes more common side effects is really just electrolyte wise. What's that? Yeah, hyperkalemia. What else? Usually I tell my patients, oh, have it with a banana, orange juice. Some garbage advice that has no bearing whatsoever on the potassium level that makes physicians feel better. The reality is that usually we check a Chem 8. You know what a chemistry is? An electrolyte panel uh, to monitor electrolytes and their renal function. Typically, it's within 3 to 4 weeks post therapy. Creatinine? Do you know what creatinine is? Yeah, yeah. It's actually a very garbage test of checking renal function. If you talk to most nephrologists, they'll very rarely use creatinine as a measure of renal function or renal health. GFR is a more appropriate, especially when you get to renal disease. GFR tends to be more effective than creatinine because creatinine's non tends to be non-specific, right? It's in muscle, which is the problem. Little old ladies who are 80 years old with 95 pounds, their creatinine may be low, but they may have good renal function. And muscular men may have elevated creatinines and normal renal function. Okay? So sometimes, sometimes the patient forces your hand in choosing an ACE inhibitor or an ARB. They'll say something in their history, and you'll be like, oh, I got to use an ACE or an ARB. What are they? Yeah, diabetes. How much protein do they need? Is protein in the urine good? Any protein. Microalbumin, urea. Any protein in the urine is bad. If you have a diabetic, you do a urine dipstick and there's urine in the urine, there's protein, start an ARB. What else? Acute coronary syndrome. We'll talk about this tomorrow, but what is acute coronary syndrome? Correct. What does that mean? Yeah, but what's happening at the plaque level? Build up, more than just build up. What happens? Ruptures, plaque rupture, which will give you unstable angina, non-ST elevation MI, and ST elevation MI. More to come tomorrow. Number 3. Huh? CKD. Correct. One more. Who said that? Good job. Heart failure with reduced ejection fraction. Good job, because you didn't say heart failure. Heart failure means nothing. It's HFrEF or HFpEF. Okay? So if someone has those things in their history, you have to start. And I'm not going to say an ACE or an R. You have to start an R. For all intensive purposes, for our clinical management, ACE inhibitors are a drug class of the past. ARBs are now really at the forefront of not only heart failure management, but hypertension management. Okay? Very robust class of drugs. All right. Next class. Beta blockers. There are two classes of beta blockers. What are they? Selective, non-selective. Which one would you think you would use for hypertension? Selective. Pick the other one. Non-selective. Why? Yeah. Why does it hit both? It's non-selective. Correct. Selective, you're implying beta 1 selectivity. And the beta 1 selectivity is where? In the myocardium. Correct. So beta 1 selective will drop the heart rate. Makes sense? Non-selective has alpha blockade. And as you know, alpha blockade will vasodilate. So no one ever says, oh, you have blood hypertension? Here's metoprolol. Because then they'll come into your office with a blood pressure of 170 over 90 and a heart rate of 51. It's not doing anyone any good. With that being said, beta blockers as a class are not great blood pressure lowering agents. And because of that, beta blockers will never be your first line therapy for hypertension. Let me repeat that. Beta blockers will never be first line therapy for essential hypertension. In fact, I'll go a step further. They'll never be second line. Beta blockers have really lost their utility in blood pressure management. We'll use it when we've used other agents and they're still hypertensive, but I'll never reach for it unless they have a couple of key things that we'll talk about. So you're really talking about beta 1 selective and beta and alpha selective. So let's start with selective beta blockers. Metoprolol. You have succinate for sustained release or extended release, or you have tartrate. This is short acting. Labetalol, carvedilol, that's non-selective. What is the what is the um oh my god. Labetalol goes here. Carvedilol goes here. Sorry about that. Atenolol, I don't can you look that up? Atenolol is like a historic medication. I haven't seen atenolol in clinical practice in a long time. It may be selective. I'm not sure. But look it up and let us know. Absolute indications. When would you say you'll be like, hey, I hear you. I'm not going to use beta blockers for hypertension. But when would you be like, oh, I have to use it? Yeah, what is heart attack? Correct. Perfect. Replace heart attack with another term. Acute coronary syndrome. Correct. Acute coronary syndrome. And you're right on point. When you have plaque rupture, you want to increase coronary perfusion. Which part of the cardiac cycle do the coronary arteries fill? Diastole. Systole is never negotiable. When you look at an ECG, QRS is QRS. If your heart rate is 150 or 50, your QRS duration is identical. It's diastolic filling time, which on an ECG is what interval? Your RR interval. So every single time you decrease heart rate, what are you doing to the RR interval? You're making it longer, allowing more blood flow into the coronary vessels. So if someone has acute coronary syndrome, you're actually right. Beta blockers. First line. You can see now we're talking about hypertension. For hypertension, will it ever be first line? Never. Plaque rupture, you have my attention, right? To increase coronary flow in diastole. What else? Correct. Aortic aneurysm. So aortic aneurysm's a funny thing. I mean, there's a lot of hand waving going on why you want beta blockers when you have an aortic aneurysm. The best example that I've actually ever really read about, or the explanation I've read about, is that the aneurysm in and of itself is a weakening of the wall and it increases tortuous flow, increasing the stress or tension on the aortic wall. You want laminar flow. And so aneurysms are very catecholamine driven. Classic example, aortic dissection. When you're dissecting the aorta, what do you think is happening to your cortisol? Up, right? In fact, when they're actively dissecting, heart rate is up, blood pressure is up, and it's the classic example is this tearing dissection, this tearing pain that's propagating down the aorta. It's very painful. It's a very cortisol sympathetic driven entity. Beta blockers have excellent anti-sympathetic properties. They block the sympathetic cascade to the heart, which is why we use beta blockers to treat an acute aortic dissection. Interestingly, in a stable aneurysm, that cortisol-driven pathophysiology is thought to be in play. And so you want to block the sympathetic activity and therefore beta blockers to reduce sympathetic tone. What else? So, yes, any arrhythmia, atrial fibrillation, atrial flutter, if you want rate control, but that's like saying start a blood pressure medication for hypertension. You're not wrong, but absolute indication. What is it? FREF, heart failure with reduced ejection fraction. And this is the one caveat that only three are validated for this. What are they? Succinate, not tartrate, bisoprolol, and what else? Carvedilol. Choose any of those three. Okay? Side effects. By the way, atenolol. Did anyone look it up? Is it selective? Thank you. You were right. Okay. Side effects. Oh, all right. Number one, rightly so, patients will not take it. The moment they start seeing sexual side effects, which is not uncommon, it's not common, but it's not uncommon either. We see it. Typically at the higher doses. Usually, when you back off on the dose a little bit, it comes back. Most of the time, most of the conversations go, "Oh, it's probably the metoprolol. Let me decrease the dose," and they're like, "Nope." They just stop it. It's very hard to convince them to go back on. What else? Yeah, I mean, that's yes. Which one? Yeah, I love that, right? I see the wheels turning, selective wheels turning, non-selective, right? From uncertainty to certainty. That's what I want, right? Conviction. Yeah, why would it be non-selective? Selective. You don't want beta 2 activity. You don't want it. Beta 2 receptors in the lungs. Beta 1 receptors have nothing to do with the lungs. So, bronchospasm in non-selective. What else? They become very lethargic. What's lethargic? Lethargy. Huh? Yeah, fatigue, no energy, overall sense of blah, right? It's pretty common actually, especially when we send them out from the hospital because after acute coronary syndrome, guess what we're doing to the beta blockers? Cranking it up. If I haven't maxed out the beta blocker by the time they're discharged, I haven't done my job. But the reality is when you see them in the office, they start having some problems. You just back off, which is fine. All right, any questions? The other thing I just want to comment on acute coronary syndrome is by dropping the heart rate, you're increasing diastolic filling time, thereby increasing coronary artery perfusion. That's number one. Number two, the other thing is that it's a negative inotrope. It works less. That's a good thing after acute coronary syndrome. It works, the myocardium works less. And because it works less, thereby it requires less oxygen consumption. And the fourth is it's got very anti-sympathetic activity. So the role of beta blockers in acute coronary syndrome or plaque rupture is multifactorial. And we'll dissect this in a little bit more depth tomorrow. But it's really important that you understand these foundations before we start adding the clinical pathophysiology on top of this. All right? So, although in the scope of hypertension, beta blockers have really lost their role, it's actually the role outside of hypertension is quite robust. Next class. Fantastic. Calcium channel blockers. Two classes. What are they? Dihydro and non-dihydropyridine. Which one do we use for essential hypertension? Pick the other one. Yeah, yeah, dihydro. The dihydros. Amlodipine, nifedipine, ipine. The non-dihydros, what are they? What is it? Verapamil. Verapamil and diltiazem. Yeah, for my upperclassmen. Which one's our favorite? Our dirty one, yeah. Which one is it? Well, one of them. Pick the other. Diltiazem. Yeah. Diltiazem. Who's ever been to the French Quarter? Bourbon Street? Yeah. It's dirty, but you kind of like it, right? It's that good type of sense that it gives you. It's in New Orleans. I spent 7 years in New Orleans, so I have tons of examples. But it's what we call down south a lagniappe. You developed it for something, but it gave you a little extra surprise, an extra benefit, right? Diltiazem is dirty in the way that we use quite clinically. And in fact, if you take a look at the spectrum of selectivity, on one hand, you have the artery, and on the other hand, you have the myocardium. The epenes are very selective. Why? What's the mechanism of action of calcium channel blockers? Fantastic. They block calcium channels. And what receptor are we talking about? They're L-type calcium channels. And the epenes have profound affinity for the arteries. So therefore, they are very selective vasodilators. The non-dihydros, verapamil in particular, is on the other side of the spectrum. It's very selective to the L-type calcium channel of the myocardium. So verapamil is a fantastic AV nodal blocker. These tend to significantly drop heart rate. Epenes, they decrease afterload. Diltiazem has a little bit of both. So an example is if someone comes in with hypertension and AFib, atrial fibrillation is an arrhythmia that typically is a tachyarrhythmia. The heart rate's over 100, 110. You want a little bit of blood pressure control, but also a little bit of rate control. Diltiazem is your friend, right? So you would want to use diltiazem because it's one drug tackling two issues versus putting them on amlodipine for the blood pressure and metoprolol for the heart rate. That's two drugs. We don't like polypharmacy. Diltiazem will be your friend. Side effect of calcium channel blockers? What is it? Correct. Gingival hyperplasia. How do you know that? Yeah. It's so tested. Ask me in my clinical practice how often I've seen it. Yeah. Zero. I don't know why. It's more an archaic fact, honestly. Sometimes you're like, I'll have to remember it. This is what we call low. uh, what is it called? Low level fruit, right? What is it? Low hanging fruit. There's no real rhyme or reason for when you're taking a step exam or a shelf exam, you're like, oh, let me spend 60 seconds and reason through this question. No, you either know it or you don't. These are the kind of archaic facts that 24 hours before an exam, you just have a list of, I gotta know this, I gotta know this. But in clinical practice, honestly, I think phenytoin, which is like an anti-seizure medication, I think the rates of gingival hyperplasia for that class is a lot better than this. I use calcium channel blockers in my practice. I've never seen it, but know it. What other thing does it give you? Yeah, why? What's that? Mm, I'll give you a hint. When during the day does it happen? Huh? Not, yeah, towards the latter half. Why? Who cares? Why is standing relevant in this situation? Gravity. Most vasodilators, if you vasodilate the artery, gravity is going to pull everything down. It's actually the mechanism of action of these selective afterload reducers is some element of lower extremity swelling. Typically happens at the higher doses. Nifedipine, amlodipine, obviously not as much verapamil, right? Because there's very little vasodilation with verapamil. But nifedipine, notorious for lower extremity swelling. Is it an allergy? Is it a side effect? Yeah, it's an inconvenience. Don't label these things as allergies because the more you label these very good drugs as allergies, you're forcing yourself to class two. And we're about to get to class two. It's no walk in the park. Okay? So, lower, peripheral lower extremity swelling, and this is dose dependent. Any other questions? Very good class of drugs. One other class. Yeah, diuretics. We're really talking about thiazide or thiazide-like diuretics. Okay? What are you thinking? What's what's that? Yeah, it's a diuretic. If volume depletes you, it'll cause some vasodilation. It's not a great vasodilator, but it's a safe drug, and so we use it quite often. What's the prototype for thiazide? Correct. And what's your prototype for thiazide-like diuretics? Chlorthalidone. Chlorthalidone. Hydrochlorothiazide is short-acting. Chlorthalidone is long-acting. Maximum dose of hydrochlorothiazide 25 milligrams, 50 milligrams for chlorthalidone. If you have to choose one of them, choose chlorthalidone. It's just a better drug. It's a it's roughly twice as potent as hydrochlorothiazide without a much different side effect profile, which is nice. Side effect profile? Yeah, they're all these random hyponatremia, hypokalemia, hyperglycemia, uricemia, hypertriglyceridemia, all these random stuff. These two are the big ones that I see often, hyponatremia and hypokalemia. Again, in about 3 to 4 weeks, check a Chem 8. Obviously, use some sense. There's they're mild diuretics, so they will urinate a little bit more frequently. So if you have like a 60-year-old guy with prostate issues, probably not the best choice. If you have someone who is wheelchair bound, probably not the best choice. Well, overall, it's a fantastic class of drugs. Any questions? So you can see thiazide-like diuretics, calcium channel blockers, beta blockers, and ACEs and ARBs. We have covered what I consider all of class 1. I would say 80% of essential hypertension can be well controlled with class 1. And by well controlled, I mean a normal blood pressure under 120/80. Now, with that being said, there are a couple of nuances. Number one, if a patient comes in and walks into your clinic and their blood pressure is high, repeat it. That's number one. Repeat it. In our clinical practice, I would say 99% of the time, the blood pressure you get in the office is not even done correctly. 99% of the time, it is not an accurate assessment. Why? My patients are always running late. Oh my God, I'm 10 minutes late. They come in, oh my God, I'm here. I'm here for my 9 o'clock appointment. It's 9:20. My nurse is like, oh my God, let's get you in. They rush them in. Sit down, take off your jacket. Boom. First thing, blood pressure. And then off they scurry into my office. Oh, I'm so sorry. I'm late. And I look at the blood pressure and it's like 165/85. No. And no matter how much I tell my staff, do not do that, it makes no difference. It makes no difference. You need to be seated for at least 10 minutes. 10 minutes. Calm and collected. Feet firmly planted on the ground. Not dangling off the side of the patient seat. Feet firmly planted on the ground, arms nice and relaxed at the height of the chest. So I pretty much ignore the blood pressure, and then at the end of the interview, guess what? I retake the blood pressure. I want to say 3/4 of the time by the end of the office visit, the blood pressure is normal. That's number one. Number two, before you even think about starting medication, lifestyle changes. Always diet, exercise, weight loss. Diet, exercise, weight loss. Salt. We are bathing in salt in the US.
Oh, doctor, I don't use salt. You don't have to use salt. I don't add table salt. You don't have to add table salt. The breads, the cheese, the pasta, the takeout, the Uber Eats. Salt, 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 salt. Canned ingredients, frozen ingredients. It's a problem. So pharmacotherapy isn't really the solution. The solution will always be lifestyle changes with diet, exercise, sodium intake, and weight loss. So if I ask you a question and the blood pressure is high, repeat it. And before you push drugs or pharmacotherapy, lifestyle changes. I usually give my patients 3 months. Get it together. 3 months. Come back. Sometimes they've gained weight after 3 months. You're stuck. Two different office readings, lifestyle changes promoted, still high, pharmacotherapy. Okay? What time is it? What is it? 8:57. Okay. I have 30 minutes. Class 2. What are they? The rest of them. Can you be more specific? Loop diuretics is interesting. Loop diuretics, when would you use loop diuretics for hypertension? Huh? If you cannot use thiazide or thiazide-like diuretics, you would use a loop diuretic. When is that? Okay, an allergy. The This is probably a premature question because you may not have had renal yet. Thiazide and thiazide-like diuretics actually have to get to the point, the mechanism of action. So you need a GFR greater than 30. So in renal patients with a GFR of less than 30, you can't use thiazide or thiazide-like diuretics. If your GFR is less than 30, your diuretic will be a loop diuretic. That's the only time you would ever use a loop diuretic for essential hypertension. Give me another class. Have you heard of hydralazine? What's hydralazine? Hydralazine is a very selective vasodilator. Very select, very powerful vasodilator. So it typically comes in, number one, it's short acting. It's short acting. So we use it as maximum dose, 100 milligrams, 3 times a day. Though these TID drugs, they're a pain in the butt for our patients. That middle dose is a problem. But because it's a profound vasodilator, it gives you some very interesting side effects. Number one, it causes Reflex tachycardia. What's reflex tachycardia? Yeah, in response to what? Which is? Yeah. Remember, cardiac output equals heart rate times stroke volume. If your cardiac output, if your blood pressure is dropping, heart rate will come up. It's reflex, it's protective. So that's a very common side effect. What's another side effect? No, no. Well, any sort of tachycardia can give you angina, but it's very selective to this drug. It's called orthostatic hypotension. What is this? Correct. Yes. What position change are you alluding to? Yeah. Going from laying down to sitting and going from sitting to standing, right? And then when they stand, all of the blood gets pulled to, they're so vasodilated, it pulls to the legs, and then they get lightheaded and dizzy. Sometimes it can lead to syncope. That's called orthostatic syncope. What's another very, it's not an uncommon side effect, but it's a very well tested side effect. Correct. Drug induced lupus. What's that? Where are you getting this from? Step? I mean, listen, they're not. Have you ever gone to the pharmacy? Have you ever picked up a drug and gotten a booklet of side effects? Yeah, take a look at any drug and just go to up to date and take a look at the drug information from the manufacturer. You literally get a booklet of things. You can tell me, hey, in hydralazine you can get gravity dependent edema. Well, yes, you can. I just said when we talked about calcium channel blockers that any selective vasodilator will give you gravity dependent edema. This is a very powerful vasodilator. So some patients will get gravity dependent edema with this. But there are certain things in terms of drug knowledge that this stuff is very selective to hydralazine. This is the stuff you need to know. Because with certain conviction, you can say, oh, you had this constellation of symptoms, that's hydralazine. You had joint pain, low grade fever with pleuritic chest pain, that's drug induced lupus. What drugs are you on? The moment hydralazine comes up, you got to be like, that's the drug. You can look at 100 different side effects and I can say it's probably a side effect. But also, not all side effects carry the same urgency. Does gravity dependent edema? That's a side effect. Is that as urgent as drug induced lupus? If you miss the gravity dependent edema of nifedipine, will that have the same consequences as missing drug induced lupus? Probably not. I think this is the lens of what these step books And they're all the same. At my institution at Stony Brook, my students are obsessed with first aid, which I think it's like material vomitus. It's just random facts with no structure, right? So so I'm not saying that those aren't side effects. I'm just saying that my perspective on these drugs and my clinical practice and what I think you need to understand and what's going to be testable for you is going to be these three things. And I'll give you clinical examples because most boards are going towards clinical examples, clinical vignettes. What if I told you there was a woman with dementia, 90 years old with dementia, coming in and her blood pressure was, I don't know, 80 over 40, and she's on hydralazine? What's that? Okay. Assume she's at a nursing home, at a facility with dementia. Hydralazine, I told you, is a vasodilator. So what's really important to make sure that patients on these vasodilators that's very important for them to do? Volume. They need volume. Can someone who has Alzheimer's tell people when they're thirsty? A lot of my elderly patients in a facility, they can't even feed themselves. So most patients in that clinical scenario should not even be on these vasodilators. They are the ones that they get hypotensive and orthostatic. There's another scenario. Most of my geriatric patients are on beta blockers. Why? Who knows? Hypertension for whatever reason. Don't tell me why you would start a beta blocker for hypertension. Maybe a history of coronary disease. Maybe they had plaque rupture and had a stent 20 years ago. They're still on a beta blocker. What if they get a urinary tract infection? These vasodilators will then cause orthostatic hypotension in someone with a UTI. Demented patient, they have no thirst reflex. Even if they're thirsty, they can't communicate that they're thirsty. So these are really, really relevant scenarios that you have to take into consideration. And if my elderly patients are on hydralazine, I either remove the hydralazine or I remove the beta blocker. Can you imagine if my little patient on hydralazine and on a beta blocker goes to stand up, the hydralazine is dropping her blood pressure, and the body wants the reflex tachycardia, wants to bring the heart rate up, but pharmacologically, they're beta blocked. So when they stand up, blood pressure drops and heart rate remains in the 50s. What is that called? An emergency. You are not wrong. That's called syncope. That's syncope. They will pass out. And they may be on aspirin, they may be on a blood thinner. If they drop down, they fracture a hip, or they have trauma leading to an intracranial hemorrhage or something like that. That's the beginning of the end. Remember, do no harm. So sometimes I look at patients and I'm like, no, get off hydralazine, get off beta blocker. If there's not a good reason for it, I start taking it back. If my patients are in their 80s, I think polypharmacy is more of a problem, right? I start really scrutinizing their medication list and starting to back off on all extraneous meds. So, reflex tachycardia, orthostatic hypotension, and drug induced lupus. And how do you diagnose drug induced lupus? Antihistone. I can ask this question in multiple different ways. What's the drug? What's the culprit drug? What's the diagnosis? How do you diagnose the diagnosis? Depending on how difficult I want the question to be. I can give you a scenario that gives you fevers, myalgias, pleuritic chest pain in a person on hydralazine and say the next best diagnostic step would be antihistone. I won't tell you the indication. I won't tell you, I'll list you all of the medications, of which hydralazine is one. You have to understand the clinical vignette, the condition, the drug, and how to diagnose it in one stem. That's 2 sentences. It's fun, right? You have to learn this stuff. As clinic, I've diagnosed 3 or 4 drug-induced lupus in my career. You really have an impact on your patients' lives. Okay, hydralazine. Next, clonidine. Clonidine's my favorite. Clonidine, everyone loves clonidine. Um, Mechanism of action, alpha 2, where? No, no. Central in the brain. Presynaptic, alpha agonist, presynaptic. It actually affects norepinephrine concentrations. What are the 2 hormones in norepinephrine? The receptors? Well, you have alpha and you have beta. So clonidine will block norepinephrine, thereby reducing alpha and reducing beta. Alpha, like we talked about, is in the arteries, so it causes profound constriction. So if you reduce the stimulation of alpha, what are you causing? Vasodilation. Beta will drop the heart rate. It will drop the heart rate. So this affects the heart rate. Most vasodilators, like hydralazine, will cause, with hypotension, reflex tachycardia. The way the mechanism of action works with clonidine, with this, alpha 1 causes vasodilation, you also get a drop in the heart rate. It's a very abnormal pairing because of this alpha and beta arm of norepinephrine. The one class of drug that will cause vasodilation with bradycardia is clonidine. It's very abnormal. When you see it, you'll never forget it, but you have to understand that this mechanism of action is different from, not only is it presynaptic in the CNS, but the sequelae of hypotension, it will not give you reflex tachycardia. Therefore, it's going to be high yield. pattern recognition. Now, can you imagine if my patients miss a dose of clonidine? If they miss a dose and it's short acting, unfortunately, it's a TID drug, 0.1, 0.2, 0.3, very tiny doses, but TID. If they miss a dose, can you imagine now what's happening in the brain? All of a sudden, you don't have the modulation of norepinephrine, and then norepinephrine levels surge. When norepinephrine levels surge, guess what happens to the alpha stimulation? Constriction with tachycardia. So they'll come in with a blood pressure of 120 over 80, and then they miss a dose, and it'll be 220 over 180. Life-threatening fluctuations in blood pressure. This is actually something that we kind of term as a clonidine withdrawal. They can come into the hospital, have a stroke, have acute coronary syndrome. They can have flash pulmonary edema. They can be very, very sick because of a medication issue. They miss one or two doses. This is such a problem, in fact, and the manufacturer, it became a safety issue. The manufacturer created a patch. There's a transdermal patch now that every 3 days they have to remove and put in a new one. It just slowly absorbs the drug in the skin over 72 hours. And then you have to remember after 72 hours, remove it, put on a new one. Because this daily 3 times a day medication was life threatening. Clonidine withdrawal. The other thing that's a very interesting side effect is they become very obtunded. Do you know what obtunded is? Like, yeah, it's a sedation, but they're non-responsive. At very high doses, it becomes a sedative. Sometimes I see patients on they take zero point 0.1 of clonidine at night to help them sleep. I don't know why. There's much safer drugs for sedation. But at high doses, you can actually just be completely non-responsive, not even to the sternal rub. They'll be extubated, they'll be off life support. They're just not communicating, not responding to verbal or painful stimuli. This is class 2. This is what I'm talking about when I'm talking about class 2. Unacceptable side effects. And then the last drug is minoxidil. Who's heard of minoxidil? Hair loss. I'm not only the president, but I'm also a client. Have you guys heard that slogan? Yes, thank you. Good. If you guys haven't Googled that slogan, Google it. It was the sensation of the 80s and 90s. The CEO of this drug company was, yeah, haircut for men. He was bald CEO. And then he got up there on national television, and I was like, I'm not only the president, but I'm also a client, right? Hair loss, minoxidil, profound vasodilator that causes a condition called hypertrichosis. Hypertrichosis or Wolfman syndrome. Wolfman syndrome. Some of us from the Middle East, we're hairy everywhere. We carry that title at baseline, right? Minoxidil will turn men and women of all walks of life and give systemic hair growth. Hypertrichosis. You have to know this. When I was in your shoes, I took my pharmacology shelf exam. There was a picture of a man with hair everywhere, and I got the question wrong. And I'm still kicking myself for it. The therapy's helping, but low hanging fruit, right? You either know it or you don't. Hypertrichosis. Mechanism of action, there's a lot of hand waving, they cyclic GMP, vasodilation. The way that I've heard it, and I don't know if this is validated, is that it has a particular profound affinity for vasodilation of subcutaneous vessels. Okay? So hair follicles, more hair growth via more blood flow. Some people get flushing with that hypertrichosis. Okay? They turned it into a topical lotion, try to sell it for hair club for men. Did not work very well. And there's actually a new surge of interest. I don't know if you guys read the New York Times article last year, but low dose systemic minoxidil for hair growth. But there's side effects. There's never any free lunch, right? It can cause you a pericardial effusion. It can cause you um, lower extremity swelling. Now, minoxidil, lower extremity swelling. Clonidine, lower extremity swelling. Hydralazine, lower extremity swelling. These profound vasodilators will give you lower extremity swelling. The only reason I'm writing it here for minoxidil is because we're talking about hair growth. There are men who go on systemic minoxidil for hair restoration, and then they can't tolerate it because of the lower extremity swelling. Usually, patients on hydralazine, clonidine, or minoxidil are renal patients, end-stage renal patients. You'll find out in your kidney block that renal patients are renin, angiotensin, aldosterone, that whole axis is destroyed, and modulating their blood pressure is no easy task. Okay? Any questions? Do we have time for some questions or no? Yeah? Can I get on this or no? Can we switch to PowerPoint? Is that easy or no?
For half of all animals in the
What's the drug? Minoxidil. Correct. Condition? Hypertrichosis. Hypertrichosis or Wolfman syndrome. Gingival hyperplasia. What's the drug? Epine. Epine. What's the class? The type? Dihydropyramide. Correct. 54-year-old guy comes in, hypertension, on hydrochlorothiazide and lodipine and lisinopril. Was started on a agent. Several weeks later, he complains of heart failure, pallor, rash, lymphadenopathy, fever. What test will give you your diagnosis? Antihistone. What's the drug? No. Hydralazine. Hydralazine. What's the condition? Drug-induced lupus. Diabetic. Referred to your clinic for refractory hypertension. She did not respond to high-dose labetalol. Her blood pressure is 156 over 88. What is the best management? Increase labetalol to 400. Increase labetalol to 400 TID. Stop the labetalol and start amlodipine. Stop the labetalol and start lisinopril. C. Stop labetalol and start amlodipine. Okay, why? Okay. All right, a lot of good thought processes there. Why do you have to stop the labetalol? Huh? Okay, so this is a real thing, Spike. The primary care thought it was a high dose. And the labetalol is 3 times a day, short acting, and the highest dose is 800 milligrams. This was 200 milligrams BID. That's number one. But number two, what did we say about beta blockers? It's not a first or second line drug for hypertension. So problem number one is you have someone with hypertension and you have them on a beta blocker. That's never. So that's number one. So you're right. You have to get them off on the beta blocker. You have no business starting a beta blocker. Some just hypertension. Just talked about the many better options involved. Essential hypertension. So A and B have to be up. Going up on beta blockers in someone whose only problem is hypertension. A and B have to be. So you're stuck between C and D. I will take C as one of the right answers. The key here is that you're dealing with a diabetic. By guidelines, I can't tell you you're wrong with C, because what didn't I give you? Yeah, remember, what condition in diabetics require you to start these wrong? Protein and food. If I had given you a urine dipstick and it was positive, the only right answer would have been D. But because I left that information out, C is still an acceptable answer. And I will take either C or D. I really just want to highlight to you, never use or continue beta blockers. You can be like, well, your doctor started you on labetalol. I don't feel comfortable getting rid of it. Feel very good. Okay, one more. A 48-year-old woman with well-controlled hypertension is complaining of persistent dry cough. After doing your due diligence as a primary care doctor, you allow asthma, postnasal drip, and thermal. Yet her symptoms persist. Chest x-ray is normal. What is the possible medication that should be considered? Yeah, lisinopril, right? Mechanism of action, bradykinin, yeah, it inhibits the breakdown of bradykinin on memory. All right. Any questions on today's session and pharmacotherapy? We're going to use a lot of this stuff this week. So if you guys understand this, you'll have the foundation of the program. Okay? All right. Thank you, guys. On and off.